Hello, and welcome to the IB Digest podcast from Takeda. I'm Will Mountford, and this is our second part of an interview with Dr. Ahmed Sultan about the use of histologic remission for ulcerative colitis. If a patient were to come to you or to one of your colleagues and say, I've done some reading, I've heard about histologic remission, I want that. I think that's what is going to, in my mind, in my body, feel like I am cured, I am safe, my life is better if I get histologic remission. How do I get there? What would your response be to them?
First of all, the key to success of treatment is an early diagnosis. So if you have the symptoms early, you need to be properly investigated and don't neglect your symptoms. Second, once you have an early diagnosis, you need to initiate the proper early treatment as well. The proper early treatment should actually, once you have an early diagnosis, you need to start the proper treatment for your case. And this is by assessing your disease severity. Like we said before, if you are young in age, have extensive disease, your CRP is high, you require systemic steroid at the start of the treatment, you are likely to need a higher and more advanced medication than the conventional therapy. And here comes the role of the biological agents or even the newer small molecules or the JAK inhibitors. Once you have an early diagnosis and you initiate the proper therapy, the third part is to have a good adherence to your medications. You need not to skip any dosage. You need to do the proper follow-up with your physicians. You need to repeat your lab test on a regular basis, assess your symptoms clinically on a regular basis, and you also need to repeat the colonoscopy on the proper time as advised by your physicians according to your case. And ulcerative colitis you usually repeat within 6 months to assess the medication's efficiency.
Well, hello everyone and good evening. We're welcome to another GI Grand Rounds. This is actually our 10th round, so we're very excited to have hit that mark. And we're very delighted to again have our wonderful panelists from Leuven. So today we're fortunate to have Bram Verstocht and Mark Ferranti, who hopefully will be joining shortly. I wanted to first thank Takeda for their continued support and for sponsoring this event. There has been, as you know, a change in the program because Dr. Muhammad Shahab from Kuwait had to sort of pull out kind of a last minute because of some personal reasons. And so our team had to chip in really in a very short time frame. But luckily, we were prepared. We had a recent case which is quite interesting, so we'll try to share that with you. So with that, I'd like to pass it on to Dr. Bram Verstock and the Leuven team to get the session rolling.
Well, hello everyone, and thanks Ala for the very kind introduction and for the invitation. I think for us as a team in Leuven, it's really a pleasure to host a lot of these meetings this year with you virtual. So, as already said by Professor Herrera, there has been a change in the program, but it's great that he, together with one of his fellows, could step in. So, Professor Herrera, the floor is all yours, together with your GI fellow, Dr. Ramita Bika, on acute severe colitis.
Okay, I think we're going to start with Dr. Nahla first, just to keep the flow. So it's fine. So
Perfect.
Bram, if you want to introduce her, I'll go.
Sure. So it's well, I was not aware of the order. So sorry, Professor Nalazam. So it's great to have you here joining virtual. So Professor Azam is a consultant gastroenterologist and professor of medicine at the King Saud University in Saudi Arabia, and she will talk us through when inflammation meets neoplasia.
Thank you very much. Hello, everyone. Thank you, Prof. Ala, for kind invitation and inviting me to be part of this interesting Grand Round series. Thank you, Prof. Bram, for the nice introduction, and thank you, Takeda, for sponsoring the event. May allow me to just the video, just close it for better signal. I will start my case, and it will be interactive, and I would like throughout the case to share with the panelists about the case. This patient, one of our patient, he is, and I'm sure, some of the history goes along with quite similar presentation to different patients, as you I will hear from you. So he is young man, a gentleman. He is currently 34 years of age. He's started actually his symptom of recurrent abdominal pain, diarrhea, weight loss, almost for 3 years prior to the diagnosis. And within these years, as you all, I'm sure you have this similar experience, the patient goes from the clinical other, mislabeled as irritable bowel, and finally, after 3 years, he underwent colonoscopy and diagnosed as ileocolonic Crohn's. That was back to 2006. 2008, he was seen in private clinic where after colonoscopy, he was started with prednisolone and tapering dose and Imuran. He developed perianal fistula, then he was referred to GI IBD center. I saw him 2009, where he was having similar symptoms, still recurrent abdominal pain, diarrhea, perianal discharge. His lab showed hemoglobin of 8.8, ESR 86, CRB around 1100, and he was admitted. His initial investigation and endoscopy showed deep ulcer in the right side of the colon and TI, so it is an ileocolonic disease. It was positive for CDF, initially treated with oral vacuum and with low albumin, so it could represent quite significant and severe disease. MRE, you can appreciate here in the arrow, terminal ileum, there's thickening and terminal ileum with enhancement, some lymph node, and right side collapse. MRI pelvis showed complex fistula. Initially, he was assessed on his Montreal classification and his disease severity. He was started with infliximab and combo therapy with Imuran for 16 doses with great responses. A subsequent MRI pelvis, it was fibrous tract fistula. His colonoscopy showed great improvement with no deep ulcer. However, he stopped treatment by himself and lost the follow-up for 8 years. So I would like here to maybe stop and ask the panelists. So misdiagnosis as IBS initially. How common you are seeing this, Prof. Pram and Prof. Ala and all the panels? And patient, if he felt well, stop the medication by himself. When I saw him later on, he said, I felt I'm doing well, so I stopped.
Yeah, I think it's a challenge, especially in Crohn's. I would say very often there is a diagnostic delay, and if you hear from patients how long they have been suffering already, it's I think in many countries it's still a big issue that GPs are not early enough referring patients. We do see some changes here in Belgium that there is more use of fecal calprotectin by the general practitioners. And when they see that something is there clearly positive, they refer quicker. But unfortunately, we see it very often that patients are diagnosed too late.
Because primary care physician aware about red flag index, use of calprotectin. So all the tools that make the patient help the patient and directing for early referral as needed.
Mm-hmm. So of course the NSAIDs can definitely make the interpretation of the fecal cal more complicated. But if you have a sky high fecal cal with, I would assume in your patient with such a severe right colonic disease, presumably we should not just attribute it to NSAIDs. And I rather would have that if something is positive, that they at least consider or they discuss with us rather than just ignoring it and classifying it as IBS with some NSAID stake rather than missing a diagnosis of Crohn's, I would say.
Yes. So if no question or anything from the panelists, I can proceed.
Maybe Professor Nala, I have another question for you because the second bullet point is I think something very relevant, which we face all very often, is patients don't want to be on lifelong therapies.
Yes.
And they ask the question, can I stop as quickly as they feel better? So how do you in your practice try to mitigate this?
Maybe at that time when the patient presented 2006, 2008, 9, maybe some they practice to have episodic giving medication or stopping medication, but more and more of growing evidence now. If you ask me now in 2025, in this high risk feature of this patient was complex perianal and extensive disease with deep ulcer, so all high risk feature of complex and high risk patient. So I would explain to them the data about stopping medication around more than 50-60%. You need to be back on this advanced therapy, and it might not be effective as he initially started. So by communication, this is the foundation complication to the patient from day one, explaining the disease, the nature of the disease. This is actually by this communication, really it decreases the burden of this thought in the patient and decrease the burden of continuing medication and explaining about continuing medication throughout the disease. In such complex, I prefer not to stop. some mild indolent course, some ileal only limited. I might tell them there is 15% risk of one exacerbation and remission most of the life. So here I can stop of some of immunomodulator. However, majority of our patients in our center, 85% are complex or moderate to severe, and we are keeping treatment long.
I would agree, and I think you highlighted something extremely important. So when patients raise that question, because it's usually the patient raising it rather than us proposing it, I think the key is to look at the phenotype where they presented with. And here you have a very good example of a patient with a very aggressive disease phenotype. So indeed, I would tell them it's not a wise decision to stop. And some might still do, but at least we can only advise them. Are there any other questions from
yes,
the
please.
faculty?
I have a very short question here. Professor Nahla, thank you so much for this very nice presentation. But I noticed that the colonoscopy done showed a deep ulcer in the right side of the colon. I could observe that it had an elevated edges and a little bit it was very suspicious. So my question is, did you biopsy this ulcer at that time when you did the colonoscopy?
Definitely, yes. This is our routine practice. The ulcer was biopsied, and initially on initial diagnosis, we usually take also for the PCR for TB and TB culture. I'm not sure about in Leuven, but this is a routine. We have to take that from the ulcer. We have to take from the 5 segment 2 biopsy each. This is the standard on our center, and it was biopsy which showed chronic colitis and inflammation and plasmapheresis cell.
Thank you.
And no granuloma.
Thank you.
Okay, so the patient lost the follow-up. Unfortunately, 8 years later, he presented to the emergency room, not to the clinic. Emergency room was typical of colonic obstruction. At that time, CT scan of abdomen, MRI pelvis showed focal wall thickening of the rectum, and immediately admitted the sigmoidoscopy performed and showed the sigmoid narrowing and ulcerated rectal mass. And this is the histopath, and unfortunately, it was diagnosed with rectal adeno-CA. Full workup done, and it was the stage as rectal adeno-CA T3N1M0, where he was received neoadjuvant chemoradiotherapy and underwent total colectomy and ileostomy. Subsequent follow-up a year later, CT scan and endoscopy through the stoma, no disease recurrence and no active Crohn's, no recurrence of the cancer, and no active disease in the new terminal ileum. 2020, later on, admitted through the ER. He had a frequent visit to ER with obstructive symptom, abdominal pain, vomiting, nausea, and reduced the stoma output. Any thought at this stage from the audience or panelists? The colon is totally out because it was a rectal, and the ileostomy was performed. But now he has obstructive symptom. What it could be the possibility at this time?
And he was without any therapy, right?
No therapy. Just he finished the neoadjuvant chemotherapy. Year later, no disease recurrence, no active Crohn's. So prefer to keep observing patient.
I mean, statistically speaking, it's usually adhesions or obstructive disease due to adhesions in a post-operative state. But, obviously other things could have developed or are happening in this patient. Yeah, he needs, imaging, I guess.
Imaging.
Yeah. Also,
yes, so it could be. Yes, so it could be still any proximal small bowel involvement of the Crohn's, recurrence, disease, either related to the surgery with adhesion. He received radiation. Also, it is a rectum, but still remotely can cause complication, or a new thing, as Prof. Ala mentioned. So he was admitted and a CT scan done, which showed diffuse small bowel dilation that reached up to 5 centimeters, and the dilation started from the stoma site. So it was admitted initially under surgeon because he had obstruction. Was called endoscopy through the stoma. It showed ulcerated narrowed areas 3 centimeters from ileostomy. Biopsy were taken from this ulcerated mucosa and showed well-differentiated NET stage 1. So he underwent a small bowel resection of this area, and the histopath showed well-differentiated NET grade G2. 6 months later, CT scan of abdomen, octreotide scan, scope through the stoma, all negative for any recurrence of the NET or any cancer, and no evidence of active Crohn's. 2023, he was asymptomatic, but during the routine checkup, and I scoped him through the stoma, I found 2 reddish ulcerated nodules as well, 2 centimeters from the stoma again, and the biopsy again, it showed well-differentiated NET. Again, recurrence of the NET. Initially, the multidisciplinary MDT discussion was carried out with the oncologist, surgeon, and we did again octreotide and Pitsen negative, no other neuroendocrine tumor anywhere. So the preferred to resected endoscopically. It was tried, but the resection was incomplete. So the 2 nodules, still the margin was affected. So he underwent another surgery for resection of recurrence of NET and almost similar. The first one was 3 centimeters from the stoma. The second one now 20 centimeters from the stoma. So he had adeno-CA. He had now small bowel and neuroendocrine tumor. He's still 34 years of age. And now we are actually after second resection, again, we are monitoring him frequently. Unfortunately, last 2 weeks ago, he came with allergy symptom, and the CT again showed the thickening in the proximal jejunum. And I scoped him, which showed likely recurrence of biopsy not yet, likely recurrence of his Crohn's disease. So now he has rectal adeno-CA, he has 2 NETs resected, possible now active proximal jejunal Crohn's. So I'm waiting for the our MDT discussion with our IBD team and our oncology for the further treatment. Any suggestion from the panelists?
I mean,
Well,
quite an unfortunate
Very
case.
unfortunate patient.
yeah. Was he ever screened for any underlying pathology? Because it's a bit unsurprising and indeed unfortunate for him that he developed twice and maybe now even a third time a neuroendocrine tumor. And then, okay, the adenocarcinoma is presumably independent because of the inflammation, but especially the neuroendocrine tumors are kind of surprising.
Yes. Now with this possibility of the third recurrence, we are doing further workup, genetic and PET scan and genetic testing, because little bit rectal or colon cancer in Crohn's or Crohn's colitis can be explained. However, this
Yeah.
neuroendocrine, actually, I will show the literature review, is not among the small bowel cancer that associated with small bowel disease and Crohn's. And he took the immunosuppression and the anti-TNF only 16 dose, and that was a long time ago. So to be related to therapy. So also his family totally no other disease in the family, no IBD in the family, no early cancer at his first degree or second degree, but we are doing further tests. But if it is started to be Crohn's, what therapy you prefer to start with this history?
Well, Professor Naila, that's a very, very interesting case, although the patient is very unfortunate to develop NETs and adenocarcinoma. So I'll just go back a few steps behind and ask you, usually when your patient develops cancer or any malignancy, and he has a Crohn's or an inflammatory bowel disease, the oncologist has a very important role in doing a lot of work in defining the tumor, defining the risk of the patient, defining, of course, the prognosis and how is he going. He takes the priority in managing such a case and putting the risk factors together. And we have to know that these tumors are rare. And of course, they may occur, but it's very unlikely, and they are rare really to occur. So there's no surveillance. We usually don't do surveillance, but in this particular case, he had colonic involvement. So surveillance should be done. So my question would be, did the oncologist advise a certain surveillance when he was diagnosed as having the tumor from the early beginning?
The first tumor, rectal 2017, rectal CA, he had underwent total colectomy and ileostomy, and I was doing a scope through the stoma. He received neoadjuvant chemotherapy according to the oncology, colorectal surgeon, and no need to do anything because he was labeled as cured. And the subsequent neuroendocrine tumor, when also initially resected with well-differentiated type and the mitotic figure goes with grade 2. They said resection is enough. Follow up with octreotide scan. We were doing this. He is a patient of mine and a colleague of colorectal surgeon, and we oncology all were involved in his management throughout this year. And with the first NET, the oncologist said only routine checkup. They did over 3 years of CT negative, and the patient asymptomatic, and they said no need to do anything.
So back to your question, Professor Nahla, and since he has a flare now of Crohn's disease, and what should we do? I think in such a situation with that history, we are going to use one of the safest biologics. I think would be something like Vido, for example. That will be because you know that most of the biologics have a risk. It's not really a high risk in most of them, but at least the safest would be Vido, and there is more growing evidence that ustekinumab also may be safe. So the choice would be one of these safe drugs. That's the answer to the question which you asked. So what are the opinion of other MDT?
Of course, the IL-23 is, of course, IL-23.
Yes.
I mean, all of these are
IL-23, P19, I think will be.
Yeah, absolutely.
Viduzumab was proximal jejunal involvement, small bowel. I'm not sure about Vido. Also, I have another patient, young, with bladder cancer. He was in Iran, and now he has active UC. Viduzumab did very well with him, but I'm not sure in this particular patient about proximal jejunal.
Especially because it's not a first line. I would say Vido, even in small bowel Crohn's, in our experience, works quite well, but mainly in fully biologically naive patients. And he has seen an anti-TNF, though very long time ago. Presumably you need an IL-23 would be a good choice also from a safety perspective. So
can I make a comment, please,
Sure.
Professor Brown? Now, the questions, of course, this patient never been, I mean, he never received treatment for 8 years. Now, I think the patient would ask the question whether his infliximab was anything to do with what he has now. And we do have a lot of patients who ask these questions, whether the medication you gave me, that gave me the net. And this is very important because, lots of patients are more blaming because I received this medication, but that has anything to do with my net. And I think that has nothing to do with his medication or even with his disease itself. And I think possibly this patient, in a way, he was lucky he was not treated. Otherwise, maybe if he developed the NAT while he's on the medication, his immune system would be even much more messed up.
Well, I think these are all excellent questions. And I think, Professor Nala did a lot of literature review on this, so I'll give the word to her. And while she's going through the slides, I think she will tackle a lot of what has been said and also the questions which are being raised in the chat.
Yes, so we'll have some quick presentation. It will answer some of this important question. Classification of cancer in IBD patient, it could be an immunosuppression, as Prof. Zahir mentioned, related or inflammation related. It could be intestinal or an extra-intestinal malignancy. If you look to the type of or risk of malignancy in IBD, it's really wide. It goes from non-melanoma skin cancer to melanoma, urinary bladder, like my patient, young man with bladder cancer, hematological malignancy, especially in combo lymphoma and TNF in combination with AZA, respiratory cancer, cholangio, not to forget, especially in PSC patients, thyroid cancer, and pancreatic cancer. If we focus on colorectal cancer incidence in IBD patient, you will find that the IBD patient has a risk of 10 to 50 per 10,000 per patient per year versus 4 per 10,000 patient yearly. The risk of cancer in colorectal usually more with ulcerative colitis. In this meta-analysis of 1,100 study with large number of patients over a long duration of follow-up, the duration, the risk, it can incrementally increase with the duration of colitis. It can reach up 20%. How about colorectal cancer in Crohn's disease? In this meta-analysis of 12 study, it was reported to have overall pooled estimate of 2.5, and the incidence of colorectal in Crohn's disease is between 0.9 to 2.2 times higher than general population. So the second question, the location of Crohn's disease, does it differ? In this subgroup analysis, we found that 3 studies reported that the colorectal cancer in ileal disease, in ulcerative ileal disease, is almost similar to general population. So colonic Crohn's is still carriers of colorectal cancer. Ileal disease doesn't actually, a risk of colorectal cancer is almost equivalent to general population. What are the risk factors that lead to this IBD disease-related colon cancer? It varies from persistence of inflammation, and this is the key. Actually, the key is inflammation. Inflammation is driven this neoplasia. Other risk factors could be diet, could be geographically, family history of colorectal cancer, PSC, and especially in UC or colonic colitis. Males also as having higher risk of colon cancer and extent of the disease. This is with regard to colorectal cancer. How about small bowel cancer in Crohn's disease? In this meta-analysis of 8 study, it was showed that overall pooled estimate with relative risk of adenocarcinoma of small bowel is 3.1 to 2 relative risk. However, we don't actually do surveillance for small bowel cancer. NET, if you look to the data on NET, the data on NET of small bowel are infrequently described in setting of Crohn's, and it is extremely rare, particularly in synchronized with adenocarcinoma of colon. If you look to the crude incidence of gastrointestinal NET, over years it has been increased dramatically. We are seeing more patients. However, reviewing the literature, only 5 cases were identified to be concordance of adenocarcinoma. It's synchronized with carcinoid tumor of a small bowel, and 14 cases of NET in CD actually reported. So, however, to find adenocarcinoma of the colon and recurrence of NET small bowel is extremely rare. I did report this case, and it was the first in the literature. By that, not to forget, actually, the question that popped up and raised by Prof. Zahir, and actually the patient as well, they would raise it frequently, the risk of cancer in the therapy, because we said could be immunosuppressive related or disease related or inflammation related. This is a different therapy, and this is a different malignancy risk. It actually varies. There is very clear, well-known association in certain disease, especially in non-melanoma skin cancer, and azacitidine and melanoma for anti-TNF, urinary bladder for AZA, and lymphoproliferative for anti-also TNF and AZA. However, in new therapy, actually still data need to be, we need more data, but overall, for the evidence that we have now, the safety profile of this new therapy are quite good. By that, I wrap up that patient with IBD at increased risk of malignancy. Primary prevention is possible. However, it doesn't actually change the need of surveillance, colonoscopy, and the key is controlling in the inflammation is the effective primary prevention. Disease duration extend, actively increase the risk. Concomitant presence of colorectal cancer and small bowel NET is extremely rare, and the risk of benefit communication always is the key for the patient. By that, I conclude, and thank you.
Well, thanks a lot, Professor Nalla, for a very interesting talk. I think something, indeed, a case which is not that common, but which raises a lot of questions. And I think it's a nice illustration why IBD still needs multidisciplinary discussion, not only with the gastroenterologists and the oncologists, but also with the digestive oncologists from time to time. So very nice overview. I don't see any additional questions in the chat, so I think you covered most of them. I'm looking at the rest of the faculty if there is any other questions from their side.
Maybe one short question. When the patient is cured from the malignancy and the oncologist would tell us that he's okay from his side, usually when do you restart your treatment? You give him the treatment for the IBD or for the Crohn's. I understand that. Yes, go ahead, please.
No, please go ahead.
Yes, just I understand that it depends upon the rate or the incidence of recurrence, but we should give our patient treatment at a time to avoid flaring his initial inflammatory bowel disease. So what's the time? Was it 2 years, 3 years?
I think it really depends case on case. In some patients, you just can't wait and you need to continue. And my feeling is that oncologists are usually way more comfortable than we are to just proceed. And we touched upon it in this case, especially with Vedo, with the IL-23s. Presumably, we shouldn't worry that much. It's a completely different story if this would be someone with a melanoma, which is known to be associated with an anti-TNF. Then I think it becomes way more complicated, and also the oncologist doesn't feel very comfortable to continue anti-TNF. So my advice would be to really discuss this on a case-by-case basis. In the patient of Professor Nalla, basically the Crohn's was kind of cured in between brackets because the colon, which was the predominant involvement side, was basically resected completely. So there, I completely agree that there was no real need to go immediately for advanced therapy after the tumor therapy, and that actually the rigorous monitoring as was done through the ostomy was actually sufficient. And up till now, in all these years, there was no recurrence of the Crohn's whatsoever. It were mainly oncological problems which drove this case.
Thank you.
Agree totally. And even latest scope through the stoma, all his a small new terminal ileum or remaining of terminal ileum are normal. Only this thickening in the jejunum, which I hope is not net again.
No, exactly.
Hopefully.
Well, let's hope for the best for your patient. So
Thank you.
we'll move topic. So thanks, Professor. Now we would like to introduce again Professor Alla and also Dr. Ramita Bigba from the American University of Beirut Medical Center in Lebanon, and also my colleague Mar Ferrante, who is joining us. And so the second case will be about acute severe colitis.
Go ahead, doctor.
Hi everyone, my name is Rami Tabiqa. I am a third year GI fellow at the American University of Beirut Medical Center. First, I would like to thank Dr. Ala Sharara for giving me the opportunity to present in such a great meeting. So my case for today is a case of a 38-year-old male patient known to have moderate to severe pan-ulcerative colitis. Diagnosed in 2018, he was started initially on infliximab and azathioprine. In 2019, the patient developed acneiform skin reaction and mild psoriasis. Then he had recurrent infusion reaction for which he was switched to the patient was in clinical and endoscopic near complete remission. The last colonoscopy was performed in 2019, and it showed a near complete mucosal healing with a short segment of Mayo 1 colitis. In December 2022, the patient missed a few doses of vedolizumab due to access issue, and then he was switched to generic tofacitinib 10 mg BID with a clinical remission, and then he lost follow-up. In June 2025, the patient presented to the clinic with severe bloody diarrhea, around 15 to 20 episodes per day. He had 3 to 4 nocturnal bowel movement. He had been taking tofa 5 mg BID, and the infectious workup was completely negative. The patient was told to increase tofacitinib to 10 mg BID, and he was started on oral steroid burst and taper. The patient's symptoms did not improve. He presented to our center in July 2025 with severe bloody diarrhea, diffuse abdominal pain, malaise, arthralgia, and fatigue.
Sorry, Rami, can I interrupt? Mike Ferrante here. Sorry for being late. Can you go back one slide? You said that steroids were added. Can you say more? Because combining steroids with the JAK inhibitor is always something we are somewhat afraid of. What type of steroids did you add there?
Yeah, so the patient presented to the clinic, to Dr. Ala clinic, and he was not able to be admitted to the hospital. So we told him to continue tofacitinib, and we added steroid because the patient was an acute severe colitis.
What type of steroids did you start? You started high dose oral steroid, methylprednisolone or prednisolone?
Yeah, it was prednisone, high dose.
Okay, yeah, that's something we would not do anymore because we saw quite some severe infectious issues with combination of steroids and high dose JAK inhibitors. So please go on.
So on admission, the patient had a white count. He was a bit hyponatremic. The CRP was 150. The albumin was 3.2. And the CTIF was negative. Lichtiger score on admission was 17. This table shows how we can calculate the Lichtiger score. The patient was admitted to the regular floor and he was started on Solimedrol 60 mg daily and Lovenox 40 mg daily. Sigmoidoscopy was performed on the same day and it showed severe ulcerative progrosigmoiditis consistent with acute severe ulcerative colitis. Biopsies showed severe chronic active colitis with ulceration. CMV was negative on both immunohistochemistry and histopathology. So what is your next choice of treatment in a patient who is currently on IV steroid and has prior infusion reaction to infliximab? Would you start upadacitinib at a dose of 45 mg daily, reinduction with infliximab 5 mg per kilo, reinduction with infliximab with a higher dose at 10 mg per kilo? Would you start cyclosporin or would you refer the patient for colectomy?
So let's look into the chat. Or do you want my response?
You can answer, Mark, or ask people on the panel to, for their opinions. Yeah.
So for sure, if I understand well, you said that infliximab was stopped at the moment that there were also high antibodies. Is that correct?
No, he didn't have antibodies. He had recurrent infusion reaction.
He had an infusion reaction, yeah. So
repeated infusion reaction.
Then it would have been nice to know it already. So that's something you already have to mention.
Yeah, he mentioned it, I think, in the first slide. Yeah.
So I would not restart that. And then, the patient also failed already. Tofacitinib UPA is probably somewhat better, but I think I would ask my surgeon already to pass by. I don't think you have time to lose here.
May I come on something? Depend on the reaction. Do you think, give him a pre-infusion, like give him a steroids IV before you give him, because infliximab is very, very valuable in this stage.
Sure.
You think that was a severe reaction that you won't consider that at all?
At the time, Zahir, it was increasingly severe. You would get shorter breath. He would the infusion had to be slowed down. He would be given Benadryl steroids, and upon resumption, the same thing would happen. So we ended up basically dropping it at the time. So I would say it was moderate to severe an infusion reaction type.
Quite suggestive. I think that restarting might cause issues.
Can I comment? I think it's a very fast patient. After ruling all the infection, like CMV, you said negative. How about C. diff?
Negative initially. That was
it's negative.
Also negative. I think he will start on JAK, so he's failed biological, and now JAK. Still, there is a room of Obada. We know there is some of the data, especially from Chicago. They have excellent experience on Obada after being failed JAK. I think with around 20-30% margin response. So still, Obada is a good choice. We need also medication with very quick onset of action. Rapidity of action is very important. So in terms of rapidity, I think P19 IL-23 is a good option. Also, it is off-label for acute severe UC. Reinduction with infliximab high dose with close monitoring and getting the antibodies prior to the second infusion is also a possibility. Cyclosporin, actually, we are shying away from cyclosporin. However, I tried it with a couple of patients. Actually, they have a good initial response. So we could just rescue him with the cyclosporin as treating him with cyclosporin as a rescue therapy until we bridge till he's out from this acute severe and preparing him for other class of either Tremfya, IL-23, or any other new oral therapy like ozanimod or etrasimod. All are this a good possibility. However, Obada can be tried after failing TOFA. Colectomy, it has to be in the in the also
So
on the
you
board,
Nala,
because and our colorectal should be on board and involved on those patients. Thank you.
okay,
You
good.
know, one small comment. You know, when I see these patients with a very high white count, the question whether C. diff was falsely negative, because we do see very high white count in C. diff colitis. So the
It
question
it wasn't too high, Zahid. It was 16,000. I mean, the guy had been on oral steroids. That's fitting with that. And both his GDH and toxin were negative.
Yeah.
And as you saw the colonoscopy, this is looks like, as my professor in the US used to say, this is like a dog's breakfast. So his colon was chewed up. I mean, this is, you could
Yeah.
have C. diff on top, but this is not C. diff.
But you think vancomycin would be of value here?
Why don't we continue if there are no, I think it's a reasonable thought. I wouldn't certainly, I mean, this is an acute severe ulcerative colitis and the guidelines are fairly clear on what to do. But maybe Rami can go on if
Yeah,
there are no other
great.
questions.
So
All right.
what we actually did for the patient, we started him on cyclosporin at a dose of 2 milligram per kilo per day with a target level of 150 to 250 nanogram per ml. We didn't wait on the steroid because the patient was already on the oral steroid and we started cyclosporin on the day of the admission. Based on the true love and Wet's criteria, the definition of acute severe ulcerative colitis is having more 6 or more bloody stools in the last 24 hours was one or more of the following criteria: pulse greater than 90, temperature greater than 37.8, hemoglobin less than 10.5, and the CRP more than 30 milligram per liter. This is the current status of hospitalized patients with acute severe ulcerative colitis. And as shown in the image, we can see that around 2/3 of the patients respond well to steroid, 20 to 25% of these patients need rescue therapy, still around 15% of the patient need colectomy, and 1% of the patient died. So based on the ECHO guidelines, every patient who is admitted with acute severe ulcerative colitis should be placed on IV steroid. All the patients should receive anticoagulation as a prophylaxis, and gastroenterologist and colorectal surgeon should be on board since admission. The response to steroid should be assessed by the third day. Patients who are not responding to steroid should be switched to the second line of therapy, or what's called the rescue therapy, and patients who are not responding should be sent for surgery. There is multiple prognostic scores used in patients with acute severe ulcerative colitis. Some scores are used on admission, and some scores are used few days later. The first score is the ADMIT-ASC score. It includes CRP, albumin, UCES scores. It's done on admission to assess the risk of steroid non-response. A higher score means a higher probability of failure. The Oxford criteria, which include the bowel movement and the CRP, is done after 3 days, and it's done to predict the patient who needs rescue therapy or colectomy. In this table, we can see that the higher ADMIT-ASC score, the higher probability of failure on steroid. This raised the following question: should we consider early rescue therapy and not waiting until the 3rd days? Now moving into the second line of therapy, the rescue therapy, what is the medication of choice? Is there a superiority of one medication over the other? This is a pivotal trial called the CSIF trial published in Lancet in 2012, comparing cyclosporin to infliximab in patients with severe ulcerative colitis refractory to steroid. This was an open label, randomized controlled trial, and it was done in around 27 centers in Europe, and the patients were randomly assigned in 1-to-1 ratio. Either they received cyclosporin or infliximab, and there was no superiority of one medication over the other. Also, we can see in this graph that the Lichtiger score drops significantly in both curves after 7 days, and the two lines are very close to each other, meaning there is no difference between both groups. Even when it's come to colectomy-free survival at 3 months, here we can see over time some patients required colectomy. However, the two lines are very close to each other, meaning there is no difference between the two groups, with a non-significant p-value of 0.6. This was also confirmed by the Construct trial published in Lancet in 2016, also comparing infliximab to cyclosporin. The patient, it was performed in around 57 centers in UK, 50 suit center in UK. The patients were equally randomized in 1-to-1 ratio. In this trial, they were looking into the quality of life using the Crohn's ulcerative colitis questionnaire and the time to colectomy. On the left side, we can see that both groups start with a very low quality of life as expected. Over time, after 3 months, we can see a rapid improvement in the quality of life, reflecting a remission or improvement on the rescue therapy. And from 6 to 36 months, both curves are stable, maintaining high quality of life. And both lines are very close to each other, meaning there is no difference between the two groups. On the right side, the two curves start at 100%, meaning all the patients had their colon at randomization. Over time, the two lines drops, meaning that some patients required colectomy. However, the two lines are very close to each other, meaning that there is no difference between both groups. So if you decided to start,
I would like to interrupt here. Of course, the data are as they are, and what I miss a bit is the safety data, but also there was not much of a difference. But of course, you need many more patients to pick up safety issues. There's certainly still a place for cyclosporin, but we didn't use it in the last 20 years, and that's specifically because of safety. We had 3 people who died due to Aspergillus or Pneumocystis cerevisiae, things that we luckily did not see yet with infliximab. Of course, you need to have access to infliximab. Nowadays, with the biosimilars, I would still go for infliximab, mainly based on the safety issue. And on top, of course, after your period of cyclosporin, there should be something else to give the patient. Now we have more options with vedolizumab and the IL-23 inhibitors, but it's certainly also an issue. It's a bridging treatment.
Yeah, I mean, clearly, if this patient hadn't had the infliximab adverse events, I think, 100 out of every 100 polled physicians would use infliximab, which brings us to the next question. So the cyclosporin for us was the only potentially colon-saving measure in this patient. But I think this brings up, Mark, the next question, which Rami is going to ask, and we'll see how people answer. Rami?
So if you
I
decide,
would like to ask the panelist, did anyone just start Obada and acute severe UC after failing TOFA? I know from Prof. David Rubin, they have
no, if they're
I think some cohort with good response. Sorry?
Rami is going to discuss that too, I think, but not in people who have already failed, TOFA in acute severe. That would be possibly a lower likelihood of response.
Yeah.
But I think Rami is going to cover that too.
So if you decided to put your patient on infliximab, what would be the ideal dose? Is it infliximab 5 milligram per kilo, infliximab 10 milligram per kilo, or the accelerated infliximab regimen based on the CRP?
Well, it depends probably on the access you have. We are very happy to have access to free goods of infliximab, so we will always start with 10 milligrams per kilogram in our patients.
Okay. So this is the famous PREDICT UC trial published in Lancet in 2004, comparing the intensified versus the standard dose of infliximab induction for steroid refractory acute severe ulcerative colitis. Patients were randomly assigned in 1-to-1 ratio. Either they received the high dose 10 milligram per kilo or the 5 milligram per kilo. And even the patient in the 5 milligram per kilo group were further subdivided into 2 groups. Either they received the accelerated dose at 0, 1, and 3 weeks, or the standard dose 0, 1, and 0, 2, and 6 weeks. And the data showed that 10 milligram per kilo of infliximab was not superior to 5 milligram per kilo in achieving clinical response at day 7. And also there is no significant difference observed between groups in colectomy-free survival at 3 and 12 months. In the post-hoc analysis, a higher proportion of patients with a low albumin and a high CRP, more than 50 milligram per liter, who received a 10 milligram per kilo had a better clinical response by day 7 versus those who received the 5 milligram per kilo. However, these data are not clinically significant. Now moving on into the tofacitinib in acute severe ulcerative colitis. An important trial to discuss here is the TACOS trial. It was performed in Europe, and they were comparing tofacitinib to placebo. The patients were randomly assigned in 1-to-1 ratio. Either they received tofacitinib or a placebo, and both groups were on IV hydrocortisone with a dose of 100 milligram Q6 hour. Here we can see that the response of therapy defined by a drop in the Lichtiger score by 3 points with an absolute Lichtiger score less than 10 over 2 consecutive days, and the need of rescue therapy and the proportion of colectomy was significantly lower in the TOFA group in comparison to placebo. Now, what about opaticitinib in patients with acute severe ulcerative colitis? This is a poster presented at ECHO in 2025. This is a systematic review and meta-analysis. They included 6 studies with a total of 66 patients. We can see in the result that despite the high colectomy rate, 82% of the patients in the TOFA group had the positive response with only 2 serious adverse events, and they were thromboembolic events. So this is a small recap of what we just discussed. I will go briefly over this picture. So every patient who is presenting with acute severe ulcerative colitis should be admitted to hospital. C. diff should be ruled out. Abdominal imaging should be performed, especially if the patient had significant pain. Endoscopy should be performed. Sigmoidoscopy is the preferred options. Patients should be placed on prophylactic anticoagulation. There is no role for antibiotics, and enteral feeding should be encouraged. Steroids remain the first line of therapy. Lichtiger score should be assessed on a daily basis. Patients who failed on steroid should be switched to the second line of therapy. Patients who are anti-TNF naive can be placed on either infliximab or cyclosporin. Patients who are already exposed to anti-TNF should be placed on cyclosporin as a bridge to vedolizumab or ustekinumab. JAK inhibitors are emerging. Patients who failed second line of therapy should be referred for surgeries. So back to our patient. The following day, the patient reported improvement of his symptoms on cyclosporin. The CRP decreased to 112, and the Lichtiger score dropped to 8. The patient reported perianal pain, and the exam showed multiple perianal grouped vesicles with erythematous base. Some are crusted over the left gluteal fold. Biopsies of this lesion showed herpes simplex virus 2 infection, and the patient was started on valacyclovir 1 gram TID. The patient developed persistent high-grade fever without any source of infection. He was already on PCP prophylaxis. He was placed on broad-spectrum antibiotics. CT scan was negative other than colitis. We did the sample for CMV, and it showed a high titer on PCR. So high-grade fever and high CMV PCR in patients with acute severe ulcerative colitis improving on steroid and cyclosporin. Could it be an invasive CMV disease, an infection, or a reactivation? Although differentiation between ulcerative colitis, acute flare of ulcerative colitis, and CMV colitis is very challenging, however, it's important to differentiate between these two entities because the approach and the treatment is completely different. This is an excellent review article published by Dr. Fadi Murad here at AUB titled Ulcerative Colitis and CMV. And it highlighted that the diagnosis of CMV colitis required the combination of the following criteria: a positive histopathology to detect inclusion bodies, a positive immunohistochemistry to identify CMV infected cells, and a positive PCR to confirm the active infection. We decided to switch our patient from valacyclovir to valganciclovir not because he had a positive PCR, but because he had a positive CMV, HSV, he had the refractory fever with unknown source. So we are trying to hit both viruses with valganciclovir. The patient was clinically better.
Rami, did you do a whole STD, sexual transmitted disease screening at that time? Because it's quite suspicious, and again, the patient is on immunosuppressives.
Yeah, this is a great question. We did later on the full panel, the STD panel. Yeah. So the patient.
Yeah, I mean, Mark, he had those done, but that was a few years ago, of course, when we started.
Yeah.
But so we reinitiated the workup, yes.
Okay, thank you.
The patient was clinically better. However, he still had high-grade fever. He reported testicular pain. We did an ultrasound that showed epididymoorchitis, and the patient was started on doxycycline. HIV test was ordered and turned to be positive. However, the CD4 count was around 1,000, meaning the patient had an early infection, and the patient was started on antiretroviral therapy. So is there a correlation between HIV and IBD? This is a nice systematic review and meta-analysis that included around 7 studies with around 57 million patients. And despite the high variability between the included study, the meta-analysis revealed that there is a significant association between HIV infection and increased risk of IBD with an overall odds ratio of 2.68 with a significant p-value. Moreover, HIV infection is associated with a less aggressive phenotype of inflammatory bowel disease. This is the INIDA trial. It's a case control retrospective study that included all HIV positive patients diagnosed with IBD. A total of 360 patients were included. 58% had ulcerative colitis, 35% had Crohn's disease, and 7% were IBD unclassified. The patient with positive HIV serology were compared with control, seronegative HIV, in 1 to 3 ratio. And surprisingly, here we can see that the requirement of biologics and non-biological agents are less in patients with IBD infected with HIV in comparing to IBD patient non-infected with HIV. This applies in both ulcerative colitis and Crohn's disease. This was also confirmed by GTATE study. It was published in the Clinical Gastroenterology and Hepatology in 2020-22, showing that IBD patients infected with HIV require less immunosuppressant and biologics. Even the disease progression was quite similar between IBD patient infected with HIV and IBD patient non-infected with HIV. Here we can see that both lines are very close to each other in ulcerative colitis and Crohn's disease patients. So back to our patient, he is currently on cyclosporin.
Rami, sorry. Can we really say that they needed it less commonly, or were the doctors afraid to give them immunosuppressive therapies?
I believe, it's less used in these patients as the data showed.
Yeah, but okay, maybe it's not that they do not need it because of the disease severity is low, maybe just because we doctors are afraid to give it to the patient.
Yeah, maybe I think, doctor, because IBD patient infected with HIV, they have a fewer side effect and a mild phenotype. For that reason, maybe they don't need the immunosuppressive or the biologics.
Yeah.
I mean, generally speaking, now with highly effective antiretroviral therapy, these patients are like normal, immune function generally, and I don't think they have an added risk if their HIV disease is controlled.
Yeah, I completely agree, but still, I think that they're
it could affect the decision. I agree.
Yeah, indeed.
Yeah.
So currently, our patient is on cyclosporin, antiretroviral therapy, and just completed induction with vedolizumab. He's doing very well with no symptoms other than mild tremor that improved with further reduction of the cyclosporin. He's gaining weight, and he's back to exercise. He almost normalized his CBC, CRP, and the albumin. However, the fecal calprotectin was still elevated. We are planning to stop cyclosporin after week 14 dose of vedolizumab. Thank you.
Rami, did the patient undergo a new endoscopy at a certain moment?
Not yet.
No.
Not yet.
Not yet.
This is essentially 3 months out, so we haven't really done another examination yet.
If I may, I wanted to come back to one of the slides on infliximab, because you indeed nicely pointed out the paper which is out there from last year from our colleagues in Australia, suggesting that maybe there is not that much relevance for intensified dose. I think in the meantime, they published some additional analyses of the trial, which is pointing in the direction that there is a role, especially in patients with a low albumin. So that this is a paper in gastroenterology they just recently published on the TDM. And I think most importantly, there is also coming additional prospective evidence that extremely proactive TDM in these individuals could benefit. So the colleagues in the Netherlands did a very small proof of concept study, which was presented at ECHO by Christina Getche, the titrate study, which was negative on its primary endpoint. But last week at UEG, they presented the post-hoc analysis of it using AI, and the post-hoc is overwhelmingly positive. So the way we assess efficacy in acute severe UC is presumably not the right one. If we just look into Mayo 3, And therefore, having AI and different ways of assessing efficacy might impact how we think also about infliximab in the future.
Yeah, I agree fully, Bram. I think most of us feel kind of like you want to give this as a colon saving strategy. And I don't think it's time to sort of like, second guess whether 5 or 10 makes a difference. I think we hit hard and we hit, quickly. I think, in my opinion, there is some at least conceptual role to this accelerated regimen that Peter Gibson and his group first champion. I think dropping CRP, as long as it keeps on dropping, you can keep the same regimen. If it starts to elevate, and we all know that patients sometimes without acute severe ulcerative colitis, they just eat up the infliximab. And it's not only controlled by oozing the infliximab, but there are multiple factors that affect the metabolism of infliximab. So I do agree that I think everybody probably in the panel would use 10 milligrams as a starting dose still.
Just a question. In case, let's put a case, in case this patient did receive IV infliximab 10 milligram, did not respond, would you give him cyclosporin?
And that's a very good question, Zahir. I mean, it has been done. There are reports of patients being saved by third line, but these are very high risk situations.
Right.
So really, you have to discuss with the patient, the surgeon. Some patients have died in the JETAID group from this strategy. So it's not to be taken lightly and should only be done in, I think, expert centers and under, informed consent, etc. I'm sure, Mark and Bram faced this in the past as well.
Completely right, and we may not forget that probably that patient still has steroids on board, infliximab, azathioprine, and then you add the fourth one. So
Yeah.
I would be very careful with that.
Mm-hmm.
Especially patients don't take surgery very easy. You explain to them, going to take the whole course.
Yeah, but better than dying from infection.
Yeah.
Exactly.
Yeah.
And that also shows that it's very important to involve the surgeon from the start so that they know about the surgery already before you consider a second or eventually third rescue treatment.
Yeah. Absolutely.
Well, if I could just make a comment about HIV, because we have a huge population on HIV therapy in South Africa, and we do see increased IBD in these patients. They get a range of autoimmune conditions, but the scenario is very different to the one that you've presented in that it's usually patients who are on ARV therapy with immune reconstitution that develop autoimmune diseases. And it's usually within 2 years of starting the ARV therapy, they usually have well-preserved CD4 counts, and then they present with these odd autoimmune conditions. And of the IBDs, it's UC that we see most often. And it's usually a milder UC. It's never as severe as we see in our other patients. And often they get by with just 5-ASA therapies. Occasionally we have to escalate therapy, and we usually skip the immunomodulators and go straight to a sort of a safe advanced therapy.
Yeah.
But
Very useful,
it's
David.
not,
I think you guys
not
have
in
a
this
lot more experience than
scenario.
most.
Yeah, but it's seldom that we see the sort of UC with HIV identified as a sort of incidental factor. It's so often the patient who's on therapy doing very well from an HIV point of view, and then develops one or more autoimmune conditions, which we suspect is due to a sort of immune recovery and sort of dysregulation of the immune system on ARV therapy.
I mean, to me, one interesting thought that I had with this patient was, he was doing well for more than 2 years on tofacitinib. Now, okay, he did cut down the dose, but usually you can recapture them when you increase the dose. But my thought was whether acquiring his HIV somehow shifted things, although, as you could see from the CD4 count, it was still high. So there was really not much immune dysfunction still probably yet, but who knows? Who knows? Maybe.
So generally, if we have a patient with HIV who's immune suppressed with very low CD4 counts, we seldom diagnose IBD. It's always intestinal TB, almost certainly. It's very rare that we would find IBD in someone who's got advanced HIV disease, and it's difficult. They can present with colitis or fistulas, perianal disease that looks very much like Crohn's, but it's often related to HIV. Very seldom would we say this is IBD in an immune suppressed patient like that.
I think that which is more dangerous than the HIV in this patient is the HSV. this patient is lucky that not get disseminated. Otherwise, he will not be surviving, this. We had patients who developed HSV hepatitis, and they were extremely, extremely sick, So I think he's lucky that he got the treatment for HSV together with the HIV.
Now, I think that's a good point, Zahir. Generally speaking, disseminated HSV, HZV happen, or zoster happen really in severely T-cell dysfunction patients. So bone marrow transplant or solid organ transplant, HIV with like severe, for example, immune lymphopenia, not usually in our setting. It happens in pregnant women, of course, it can happen. But generally speaking, I would say it's exceptionally rare. I don't know, Mark, have you seen any case of?
Luckily not.
Yeah, luckily not. Good.
Luckily, we of course we do see some infections, but luckily they're quite rare. But that also means that we have to be extra cautious that we do not forget about them if you do not see that common.
Absolutely. Yeah.
So I think we have to wrap up. I would like to thank the speakers for the very interesting cases, challenging cases. And for sure also the panel, and we hope to see you soon during one of these other rounds, or hopefully soon also live. But let's be
and I want also just take the opportunity to thank also you and Bram, the panelists, everybody who has joined us, and to thank Takeda again for their continued support of this activity. And thank you, everyone. See you in December.
Bye.
Take care.
Thank
Bye-bye.
you. Thank you. Thank you all.
Bye. Thank you.
Bye.
Hello, and welcome to the IB Digest podcast from Takeda. I'm Will Mountford, and this is our second part of an interview with Dr. Ahmed Sultan about the use of histologic remission for ulcerative colitis. If a patient were to come to you or to one of your colleagues and say, I've done some reading, I've heard about histologic remission, I want that, I think that's what is going to, in my mind, in my body, feel like I am cured, I am safe, my life is better if I get histologic remission. How do I get there? What would your response be to them?
First of all, the key to success of treatment is an early diagnosis. So if you have the symptoms early, you need to be properly investigated and don't neglect your symptoms. Second, once you have an early diagnosis, you need to initiate the proper early treatment as well. The proper early treatment should actually, once you have an early diagnosis, you need to start the proper treatment for your case. And this is by assessing your disease severity. Like we said before, if you are young in age, have extensive disease, your CRP is high, you require systemic steroid at the start of the treatment, you are likely to need a higher and more advanced medication than the conventional therapy. And here comes the role of the biological agents or even the newer small molecules or the JAK inhibitors. Once you have an early diagnosis and you initiate the proper therapy, the third part is to have a good adherence to your medications. You need not to skip any dosage. You need to do the proper follow-up with your physicians. You need to repeat your lab test on a regular basis, assess your symptoms clinically on a regular basis, and you also need to repeat the colonoscopy on the proper time as advised by your physicians according to your case. And ulcerative colitis you usually repeat within 6 months to assess the medication's efficiency.